So thank you for everybody who's registered for this seminar this afternoon. A big thank you to everybody. Obviously, you all know that this is being hosted by Lyme Disease UK. And a massive thank you to Dr. Nicolaus for giving us his time this afternoon. You'll all notice that during the event, your audio and video will both be off, so as not to disrupt the flow of the seminar. If you have any problems, you can use the chat box at the bottom of your screen, and we have two co-hosts standing by if anybody has any problems. Dr. Nicolaus will give approximately 20-25 minute presentation, and we'll then take questions that have been submitted to us prior to the event. If we have any time left at the end, we'll try and get some questions out of the chat box. So there's quite a lot of us in now. So I'd just like to introduce Dr. Nicolaus. Please excuse that I read this because you've had a long career. Dr. Nicolaus is a world-renowned Lyme expert, having dedicated his career to the research, diagnosis and treatment of Lyme and other tick-borne infections. He has treated over 27,000 Lyme patients from over 80 different countries. In 2006, he founded the BCA Clinic, BCA Lab and Research Facility, and the BCA Training Academy, gaining worldwide recognition and praise for establishing successful diagnostic tools and treatment protocols for Lyme patients. He also founded Infector Lab in 2016. Dr. Nicolaus currently divides his time speaking at conferences and webinars, training medical practitioners in diagnostics and treatment protocols, and furthering global research in tick-borne diseases. He provides mentorship and training to doctors and clinics around the world and offers support for practitioners and patients with complex medical histories. So over to you, Dr. Nicolaus.
Okay. So a very warm welcome from me as well. So I was very excited when I was invited to the 2 days webinar. And so this is a very specific one, which I have in mind today. It's just a reflection of my past 30 years staying in that field. So hopefully. So I want to summarize a bit what had happened in the past 3 decades and what my personal track was within that long time taking care for a patient with tick-borne diseases. So first of all, if we want to understand tick-borne diseases, we have definitely to understand much better what ticks are and the relationship of ticks to animals, specifically the mammals, and therefore we have to go back a long time back in history to get that needed understanding. So the evolution of ticks is a very old story and started for more than 100 million years ago, much earlier than we will learn a bit later in the following slide regarding humans. So recently, around 4 years ago, there was interesting article published. And one of the Caribbean islands, they had found a tiny piece of amber, and in that amber they have found ticks parasites at feathered dinosaurs. And you know, these ticks, which are more than 99 million years old, which you can see on the right hand side of the slide, are looking quite being the same as the ones we are very familiar with in the current days. So and that means it's a very long time of evolution, and these ticks have a long advantages in learning how to survive and how to bother us humans. And if we compare that with the history of humans, so there was very much time in between. So if we think the story of the Homo sapiens will start or has started around about 300,000 years ago, compared to more than 100 million, you can imagine that this is very complicated. So looking still in history, and probably many of you have heard from the Ötzi. So this was the Iceman who was found beginning of the 19th in the Ötztal Alps, very close to the Austrian-Italian border. And interestingly, when they started to investigate into the mummy, it came up, and that was also several times published, that the Ötzi was probably the first known Lyme patient. So relatively soon after starting these investigations, they have found evidence based on PCR testing of Borrelia. A bit later, we got also evidence that this guy has also suffered from a Bartonella infection at the same time. So a long time ago, but is still demonstrating how serious this problem was in those days as well. So otherwise, the history of tick-borne diseases is compared to the former information quite new. So the first reports about specific skin pathologies had been done by Dr. Alfred Buchwald at the end of the 19th century. So when he described first time a very well-known skin condition, which we see most often accompanied to chronic forms of Lyme disease, so the so-called Acrodermatitis chronica atrophicans. So a bit later, 30 years later, another researcher, Arvid Afzelius, has described a skin-like, a ring-like skin rash, which he named erythema chronicum migrans later on. And another 10 years later, two other researchers, Garin and Boujardou, they have described first-time patient with meningoencephalitis and having at the same time very painful sensory radiculitis and an erythema migrans after a tick bite. And so that was first time the suggestion that these health condition had been definitely caused by a spirochetal infection. Another 10 years later, in the mid of the 30s, there was another report about neurological manifestation after contact with ticks, so Ixodes ricinus ticks. And this manifestation was described as a meningoencephalitis as well. A bit later, another researcher, Dr. Banwar, has described several cases of chronic lymphocytic meningitis and polyradiculoneuritis, and always at the same time as they have found these specific skin pathologies, so the erythemaceous skin lesion at the same time. And much later, 50 years later, an American dermatologist, Dr. Bernard Berger from Southampton, New York, has noticed that the former thought that we are dealing with the chronic forms of an erythema was not anymore correct, and they changed simply the term of this skin pathology to EM, erythema migrans. That's it. Interestingly, in 1975, there was a local onset of an epidemic in a little village called Lyme in Connecticut, where many people, including young patients, showed up with health condition which have been close to juvenile rheumatic arthritis. And it took at least, so this guy was Alan Steer, who was asked to run some examination and to find out the reason for that epidemic. And it took exactly 5 years when another well-known researcher came into that field, Dr. Willy Burgdorfer, who was able to isolate the Borrelia bacteria out of the gut of ticks. And so the Borrelia species, what was and the spirochete, which was found in the tick's gut, was later on named according him in Borrelia burgdorferi. So let's go a bit forward. So as we all know, since beginning of the 90s, we have dealt with so-called evidence-based guidelines. So the first one, which had been published, had been from the IDSA, Infectious Diseases Society of America. Much later, also from other medical societies. So here in the UK, the NICE guidelines, which had been renewed a couple of years ago, and a bit later than IDSA, we got introduced the Eyelids Guideline. And this is definitely something of importance because when it comes to the chronic stages of infectious diseases, they are relatively good represented in the guidelines, and we can definitely accept the diagnostic and management means treatment of acute stages, but there are big difference regarding the notification of chronic stages of these spirochetal infections. So it's quite common for all of the guidelines to accept that patient after tick attachment, after transmission of the infection of Lyme disease, can show up for a long time with chronic symptoms and complaints. But when it comes to the courses, there's still a big difference in the acceptance of what it really is. So while IDSA and NICE does not accept anymore an active infection, so is postulating a status after infection. So what we are the post-Lyme syndrome, for example. Eyelids was the first medical society which has accepted that in chronic stages we are still dealing with an active infection, and which is still maintained by these by the presence of these bacteria. And this has definitely led to massive problems later on. Many patients, probably many of you listeners today, have learned about the consequences about this still ongoing discussion. So that means if we are postulating that there is no more illness, no more infection, then no specific antimicrobial treatment is anymore required. And this is what most of the patients I have seen have noticed by their own. So they have been finally diagnosed with Lyme disease, but have been treated for a certain time, means somewhere between 2 and 4 weeks. It was seen as to be sufficient enough as a proper treatment. But all of you know definitely about the consequences of such a decision. Now I have some technical, so no, okay. Sorry for the technical problems. So I want to go now to be in more details of tick-borne diseases and the most common seen obstacles. And on this slide, you will also get very important information. So it's not only Lyme which patients are presenting. It's most often, in most of the patients I have seen, I would suggest in more as 90% of the patient, we are dealing with multiple chronic infection at the same time. some of them are reactivated, and some of them are definitely not transmitted via tick bite or another bloodsucker. That's more or less presence of other opportunistic bacterial or viral infection. But the most important message is that meanwhile we are dealing with these chronic multiple infectious diseases syndromes in the overall majority of our patients. And part of the problem could be bacterial infections. So the real tick-borne diseases, beside Borrelia, we know about problem with Bartonella, Ehrlichia anaplasma, rickettsial infection, and tularemia, but also some airborne transmitted infections. So this is a group of opportunistic germs, including chlamydia species and mycoplasma species at the same time. But we can see also parasitic infections, fungal infections, and viral infections at the same time. So why it is so complicated in dealing with tick-borne diseases, specifically with Lyme? So what are the challenges? At the beginning, I have mentioned that ticks and even these tick-borne diseases have a long evolutionary advantage. And so these bacteria have definitely learned to survive and to escape from certain threats. So this includes also something which we call the pleomorphism. That means so the bacteria can be present in one organism at the same time and in different states or different forms. And how does it look like? You can see on those slides. So at the beginning, we are most often dealing with the spirochetal form of these bacteria, but it took only a certain time when Borrelia will start to move in different other states. So we have an intermediate state called blebs, for example. You see here still the final tails before it's the change in the round body forms, which we called in former times the cystic forms, has been completed. And another very challenging problem you see on the right-hand picture. This is so-called onset of biofilm formation. On top of the pleomorphism, these bacteria are always able to enter the intracellular environment of any other body cell. This is what Borrelia is doing most of the time. It's a bit different for some of its co-infections. So Bartonella and Babesia isn't entering all other body cells. They are very specific, entering the red blood cells, which is causing specific other symptomatology later on. And beside the pleomorphism and intracellular onset, we have recently found other condition, and this is what we meanwhile call the stationary phase or the persister forms, which had been 2 years ago confirmed for Borrelia and in 2020 for Bartonella. And if we consider all these different escape and survival strategies, I guess then it's well accepted that that could lead to massive problems on one hand in diagnosing these infectious diseases, and on the other hand to find the right treatment approach later on, which is definitely able to target all these different forms and phases of these bacteria. Beside these pleomorphism, for example, we are also dealing at the same time with certain other health conditions, and chronic infections in general, independently if it's viral, bacterial, parasitic, can lead to massive impact on our immune system. So we can find at the same time immunoglobulin or subclass deficiency or excessive exactly the opposite, immune overactivation, which can lead to massive problems in treatment later on. Very common in a very high percentage of patients. We see gastrointestinal issues, different ones. On one hand, disruption of the microbiome based on the invasion of these bacteria, but also conditions like a SIBO syndrome, leaky gut, gluten or other sensitivities could be part of the problem. And some patients are showing up with enzyme deficiency or nutritional deficiency at the same time. But many other health conditions could have impact finally on the progress of these patients responding on treatment. So some of these issues could be mold, multiple chemical sensitivities could be part of the problem, and intoxications with environmental toxins, heavy metals. But there's also some influence by genetic predisposition, which can lead to methylation problems, better known under the term of MTHFR polymorphism, which could have influence in the absorption of the medication or supplements, the utilization, and finally the detoxification of chemical substances. Mitochondrial dysfunction are also most often seen. A certain percentage of patients is dealing with dysautonomia and resistant POTS syndrome. Sleep orders are very often seen, and endocrine disorders. So finally, borrelia can definitely get impact in any of the hormonal producing organ systems at the same time. And around about 90% of the patient are dealing with chronic pain syndromes. So quite challenging in summary. Another finding which is getting more and more interest is definitely the mentioned onset of biofilms. So it's really essential to take care for that that issue. So any treatment protocol should today include certain supplements or biofilm busters at the same time. Otherwise, you can't expect really a good treatment outcome. So, and this is definitely what bacteria and viruses have learned in that evolutionary process to adapt their strategy to survive. And part of this strategy is definitely the onset of biofilm formation. And it is also so important not only that patients are aware of that issue, so we have definitely to spread this information to many other of the GPs and healthcare professionals to get a better understanding. Otherwise, if we don't notice about that, we can definitely expect some more frustration and treatment failures later on. So interestingly, biofilms are not only seen for bacterial infections. So the first biofilm formation, which had been described in the literature, had been based on viruses, and this is also something which is meanwhile suggested for these long haulers of COVID-19 infection. So it looks like that we are dealing with the same phenomenon as with Lyme biofilms, and also certain persistent forms of these viruses, which can bother a patient for a long time. And so actually it's suggested that up to 10% of the patients who got an COVID-19 infection are dealing with these issues as well. So, some more information about the biofilms, and what does then biofilm core? So we have definitely evidence that in these biofilm formations, the bacteria or even the viruses are much better protected, and so it's quite hard for antimicrobial substances in general, but specifically for antibiotics to approach the bacteria and finally to neutralize or to kill them. And this is something we have to take in consideration. Otherwise, there's some risk of treatment failures at the same time. So that means beside any antimicrobial treatment, we have to include a biofilm buster to get faster and better access to these bacteria and viruses at the same time. Interestingly, when they are in these microcolonies, you can find the viruses as well as the bacteria in the different stages, and so the bacteria can easily change from one status to another, and this knowledge is also of importance. So if we don't take care for that issue, it could really become a vicious cycle, and a patient can with very frustrating treatment outcome. So again, meanwhile, it's essential to include biofilm busters to any antimicrobial treatment if we want to get a very good outcome. So let's talk a bit more about the treatment approaches in those days. There has been definitely a very big paradigm shift over the past couple of years regarding diagnostic, treatment and care of Lyme patients. So our believing, what we have started with in the 90s and in the next decades to use a certain bunch of different protocols is not anymore in general recommendable. So it looks like that every patient is an individual human individually responding on treatment, and therefore we need meanwhile a very tailored medical approach to get the improvement out of the treatment. And so that means a good treatment meanwhile is definitely based on a holistic, patient-centered and a very personalized approach. Otherwise, we can't expect good outcome. And how does it look like? Should show the next slide. So this is my understanding in setting up good treatment and expecting good outcome. So it's like building a very proper house. You will definitely start with a good basement, and the basement is definitely at the beginning. Seeing patient first, the anamnesis, the inspection, examination, to get the first overview what it is. In addition, we need some diagnostic tools, so the lab test to find out or to get confirmation for our first thoughts and suggestion. And when it comes to treatment, as I said, a holistic approach is definitely the best recommendable way of taking care for these very complex chronic infections. So the approach should definitely include antimicrobial substances that could be the conventional antibiotics or herbal antimicrobials. A certain lifestyle and a certain diet is definitely required to support the patient in approaching a good outcome. Dietary supplements and some detox treatment is definitely needed So if we are dealing with other accompanying health conditions, supportive medication could be required. A good pain management is essential. Also, treatment without using any medication, so physiotherapy, exercising are best recommendable. Stress management is recommendable, and last but not least, mental coaching and social support is needed if we want to get a proper outcome and a high success rate. And if we can offer all of that our patient, then I'm very confident that we have good chances to reach that. So I want to summarize a bit about my own experience over the past 30 years. So it's quite a while that I've seen my first Lyme patient, beginning of the 90s. And so what had been the milestone for me to improve myself, or what is essential, what I've learned over the time to get this good outcome and to offer good diagnostic and good treatment to the patient. So first of all, and this was the first I have seen, you have to listen very carefully in these first contacts to your patients. I would suggest that 60–70% of the information to find the right diagnosis is definitely given by the patient themselves, even in these first appointments. And at the same time, the inspection and examination is needed because many of these tick-borne diseases are presenting very specific skin conditions, and without any examination, you are lost. You can't find the right diagnosis. On the other hand, and this was also of importance for me, so in the guidelines, Lyme disease or its co-infection are very often represented by so-called safe clinical signs. But I noticed very early that there was a big bunch of non-specific health condition at the same time, and seeing more and more patients, it was quite easy to get a better understanding, because these patterns of unspecific symptoms could also give you a lot of information finally to get the right diagnosis. And so basically observation is needed on that track. So the next sign was the introduction of the guidelines was quite early, even in Germany, where I've started my career. And interestingly, I noticed very early that many of my patients I have seen in those days had failed the criteria of the guidelines. So it was quite obvious that many patients are definitely not best represented by the guidelines. So it wasn't a big issue in the acute stages. So the stage of an erythema migrans, then it's quite easy, or even the disseminated stages, also seen as an acute stage. But when it comes to the chronic stages, so many doctors and also patients had been lost. And this is where I'm still struggling, and I will show a bit later another picture to explain that a bit more. The next point, and that started for me, so mid of the 19th, so around 95, I have noticed there was definitely something else as Lyme. And this is when I started to become more focused on its co-infection. And today I have to mention that the co-infection really playing a crucial role in the diagnostic as well, and as in the patient management care. Ignoring the co-infection, and that happens too often still, could lead also to very bad outcome of the treatment. Diagnostic. So at the beginning, I had only access to the two-tier testing. Looking for the antibodies, IgM or IgG antibodies in the so-called two-tier testing. But that was definitely not very exciting because out of that testing, you can only get confirmation if there was a contact or not, but other information had been not available. So with my background, having done a PhD in immunology and being a member of a transplant unit, for us it was quite obvious that we had to do everything to improve the diagnostic tools. And Germany was lucky to have had a big research groups in Munich and in Berlin to look for these other diagnostic options. And very early we got access to what we today call the T cellular testing. So the first generation, the lymphocyte transformation testing, which had been used from the second half of the 90s in Germany for diagnosing of tick-borne diseases, was used in the 80s in transplant medicine. The big milestone was when we got introduced the ELISpot technique, and meanwhile we are in the third generation, the so-called iSpot, which includes other cytokines at the same time. And this is still a milestone in getting the right and proper diagnosis, as well as a good monitoring of patient while including these types of testings. And other diagnostic tools have been introduced, like the FISH test. It's a specific method which was first introduced by Igenics for Babesia and Bartonella infection, and other approaches like multiplex PCR was definitely much appreciated. So the next milestone for me was definitely when I noticed that monotherapies, which had been almost recommended from the beginnings after introducing the guidelines, hasn't done a really good job. Also mid of the 90s, I have started by myself in combining the antibiotic from certain antibiotic classes. So based on the literature, to use tetracyclines and macrolides at the same time. And that have definitely led immediately to a much better outcome. And specifically under the aspect of pleomorphism and the intracellular presence of all of these tick-borne diseases, it is 100% needed to go minimum or a combination of two. Meanwhile, we see very often triple courses of antibiotics at the same time, or several antibiotics and herbal antimicrobial at the same time to get a much better outcome. And also very important was when I get a better understanding to use the antimalarias. So, for the treatment of these parasitic tick-borne diseases, Babesia, it was almost recommended to take one compound or hydroxychloroquine or artemisinin later on. But I noticed quite early that there was probably a more important effect as well seen while introducing antimalarias, and that was to make changes of the intracellular environment. All antimalarias will cause a more basic environment, and this is nothing which these bacteria and parasites want to have. So as soon as it's coming to more to less acidity in the intracellular space, these parasites and bacteria will try to leave that safe environment, and then it's much easier when they left showing up in the bloodstream to take care for them at the same time. Also important is definitely the fact that with these suggested 2 to 4 weeks treatments, which you can still read out of the guidelines of IDSA and the NICE guidelines, so with a maximum of 4 weeks treatment, this very often, that has very often failed, and we should definitely go for treatment as long as patients are presenting safe signs of the infectious diseases. So that means still presence of certain symptoms and complaints, and based on additionally tests like the T-cellular testing, where you can read out activity of these certain infectious diseases, then you can adapt this information in long-term approaches, which are most often needed in a patient with chronic stages of these infections. Probably I was one of the first doctors in Germany, not in hospitals. In hospitals, was quite often to use IV drips for the treatment of Lyme disease, specifically the ceftriaxone is one of these first used IV antibiotics. But when it comes to offer IV services in normal practices, I probably was the first or one of the first in Germany introducing that treatment method, and I'm still convinced if there's a need for antibiotics, the better way is definitely the way introducing IV antibiotics, because you can very much fasten the treatment. You have a much better insight about the response on treatment, and if there are certain intolerances or side effects, you can much easier respond on this information and setting up a good combination of antibiotics and to get much better an approval of an effective treatment. So also important, and this was very early in the 90s, we have learned that patients have definitely the need for some accompanying treatments. So one of the first supports I have introduced was the introduction of pre and probiotics to reduce the GI side effects, and this was definitely an essential improvement. So before we had around about 30% of patients showing up with antibiotic-associated diarrheas, and when we consequently put patients on pre and probiotics, we had been able to reduce that rate on less than 5%, so on average 2 to 3%, which was quite good, and which has also led to a much better tolerance in long-term treatment with antibiotics. So in general, and that came out of one of my slides. So these holistic approaches I have introduced very early here in my treatment concept, and so the multi-drug treatment, the modular treatment approaches, and to see these illnesses from a completely different angle, not only focus on the eradication of these bacteria, taking care also for the other accompanying health condition, and to introduce immune enhancers because of the immunosuppression was quite essential and has always led to a much better outcome. And another big milestone for me was so when we have done the first trial with triple drug combination, learning from the treatment of tuberculosis to introduce this medication group of tuberculostatics, so very well known as rifampicin and some others. In doing so, we have also noticed a very tremendous better outcome because the tuberculostatics are a very important substance class of antibiotics, specifically for intracellular bugs, and this is still ongoing. So in here in the current treatment approaches, mostly one of these tuberculostatics is almost included in the treatment approach, and this is more or less a guarantee for a good outcome later on. And in general, so coming to an end of my personal learnings, it's so essential to approach patient with open eyes, open ears, and to start really systemically the detection, the analysis, and the treatment later on, also to all the accompanying health condition. Otherwise, you will be definitely lost. I just want to summarize it. So at the end of my presentation, what is most important at the moment in offering patient a very good treatment approach. So looking back in history, at the beginning, I was only able to offer my patient the conventional treatment approach. That means at the beginning mono treatment, then a combination of antibiotics. And for all those ones who haven't tolerated the antibiotics, we had been able to offer alternative treatment protocol. That means introducing herbal antimicrobial in patients who had allergies or intolerances on antibiotics. But nowadays, a very good treatment approach is definitely combining those both approaches. So there seems to be a general trend internationally that more and more Lyme specialists are offering patients what we now call the mixed treatment protocol. That means combining conventional antibiotics and alternative herbal antimicrobials at the same time. And there's really good evidence in the literature that we can easily do so, and that will definitely lead to much better tolerance. It's more convenient and softer for the patient to stay on long-term treatment. And also necessary is to treat inflammatory processes at the same time and to enhance the immune capacity. Otherwise, you can definitely get much longer times of treatment. So now at the end, summarizing a bit. So for the future and what have been the most recent advances over the past 5 years for me, this is definitely the introduction of the T-cellular testing, which is also more known under the term of iSpot technique. So this is essential even to learn from patients where they are under treatment. So I see that the newest generation of T-cellular testing not anymore as in the first line as a diagnostic tool, which is definitely an excellent one. I think it's absolutely needed to introduce this type of testing for the monitoring. So if our aim is to deal best with the patient, that means to see how patients are responding on the different treatment approaches, it's essential to go in parallel on this testing all the time. And we can forget after the basic diagnostic, the antibody testing, this is essential at the beginning to get confirmation for the infection. But when it comes to treatment and to the monitoring, we need a completely different way of diagnostic tools, even to get that missing link. So I'm very hopeful in the future that other forms of new diagnostic tools, specifically what we call the next generation sequencing method, will improve our diagnostic, which had been shown in the past couple of years. And I expect some more impact on diagnostic as well as on treatment. So that means it's only a matter of years where we can read out of our genes what is the best antibiotic. Are there any forms of resistance? All that information is still on our genes, and with this type of diagnostic tools, we have all these options to improve diagnostic and treatment in the future. And it's an ongoing thing at the moment. Also very interesting over the past couple of years, so starting in 2016 was the introduction of other let's say, antimicrobial substances which are not seen as a real ones, so like the disulfiram or another substance, the methylene blue, is becoming more and more popular in the treatment of Bartonella infection. So these medication, which had been developed for completely other medical indications, but noticing later on that it could be an alternative option to replace antibiotics or in combination with antibiotics to get a much better outcome finally. This was an interesting finding for me. And there are definitely some other promising treatment approaches. It's too early to see that that is something which all patients have to get. But so if we look to these alternative options, introducing peptides or the small oligonucleotide treatment, so SOT treatment, stem cell treatment, definitely will offer some in the future if we will get a much better understanding in using that technique, and treatment options like hypothermia and others will definitely be very supportive and beneficial for patients to get their treatment improved later on. So, and also I'm very thankful for all the work organizations like LD UK and other patient support groups in Europe and worldwide have done over the past 2 and more decades. So without this support, we haven't been able to spread the word to all the patients who have failed in the system. And with your support, constantly support, we will be definitely able to hopefully to get patients much better informed, and hopefully inviting also healthcare professional to get those healthcare professional much better trained in the future. So let's come to the conclusion. So what I've observed over the past 3 decades was that there's still something new to discover. There's no end, and we have to accept that, and we have to learn out of that. So we have definitely to increase the awareness. This is essential, and otherwise we won't get acceptance by the medical establishment. And we have definitely to keep in mind that we are still not mainstream. So based on the current guidelines of IDSA, of NICE and others in other countries, and we have definitely to still to work on because it's so complex, these diseases. We have to work on improvement, constantly improving our diagnostic tools. We have definitely to work on better treatments, and this is definitely possible. And what I've noticed in my personal experience is definitely that within the past 30 years, there was year by year progress seen. Sometimes it's still very slow, but we are progressing. So this is quite obvious. And I have also noted that the success rates have constantly improved over the past 30 years. And you know, my believing is still as better prepared we are, as better our knowledge and skills about these tick-borne diseases are, as better will be the outcome. And I'm still convinced that for a very high percentage of our patients, we can definitely get very, very good outcome, and in many cases also a complete recovery. And this is definitely so important, and this is what we all want. So we need your support to raise more awareness, to improve the training, medical training of healthcare professionals. There's still a certain need for long-term treatment, which we have to provide to patients. Otherwise, there's no chance to get a high percentage of patients with chronic infection really on a good track with good recovery and less symptoms and complaints. There's definitely actually not available a gold standard. It's we are still in a process of improvement, but again, I'm very optimistic to go forward. Oh, sorry for the interruption. So now I'm at the end of my presentation. I'm happy to answer all your questions.
If you could just stop your screen sharing, that'd be great. There you go. Thank you for that informative presentation. I'm sure everybody got lots of information. We are scheduled to slightly overrun our time. So if anybody wants to stay on for an extra 10 minutes, we'll obviously go with the questions, and I'll pick a couple from the chat box as well. But what we'll do is we'll save the chat box, if that's okay with you, Dr. Nicholas.
Yeah, that's...
maybe send you a selection of questions from the chat box. Would that be okay?
Yeah, that's okay with me.
Okay. So I'll take a couple that were submitted. I mean, some of the things you've probably covered, but these are a couple that were sent in. So this is a good question. What research areas do you think are most exciting at the moment, either in diagnostics or treatment?
Both, definitely. So, so as I said in my presentation, there's definitely a lot of space to improve the diagnostic tools, and this is ongoing for sure. There are many startup companies developing new types of test techniques, even to get faster and a better and reliable test system. And it's the same for the treatment. I guess we definitely need some more clinical trials. This is definitely still a big lack. But on the other hand, we are definitely getting a lot of feedback from many colleagues using new treatment protocols. And as I said, we are going better and better.
Okay, this question is from the chat box. So, which pathogen is most likely the cause of neurological symptoms?
Oh, there are plenty of them. So in general, and this was published by a colleague of mine, Professor Bechter. So in the first line, I would definitely see Borrelia and Bartonella, but some other co-infection are also causing very often neurological problems at the same time. So some of the viruses, Professor Bechter 20 years ago published that any forms of infectious diseases can cause or can get access to any part of the nerve system, causing those problems.
Okay, just to let everybody know who's attending, if anybody has to leave at 5 o'clock, this is being recorded, so no problem if you have to leave. We'll be sharing it at a later date. Okay, so another one that's been sent in, quite personal to one person. How long should a person give a protocol before you know it's working? At which point would you decide to continue or change the course of treatment? I've done 10 months on oral and IV antibiotics with no progress.
Yeah, no, this is definitely a good question, and very often I got this very often. So I would suggest that you should stay minimum for 6 to 8 weeks on one protocol until thinking about doing any replacements or changes. And sometimes it's a very subjective matter. For this reason, I mentioned quite often in the presentation, we should include in those patients the T-cellular testing, even to find out if there's really a good response or not. Sometimes patients are not noticing anything quite a while, but in the background, the antimicrobial substances are doing quite a good job. This could be seen in a certain percentage. And in another cohort, you will find patients who don't notice anything, and who do not respond in a proper way, and then we have to find out why. Is that based on the resistancy? Is that based on failures of the antibiotics, or is that determined by other health conditions at the same time? You know, so pre-genetic disposition like MTHFR polymorphism could also lead to very bad outcome when patients are not able to absorb in a proper way all the antimicrobial substances out of the GI tract, or they are not able to utilize the medication. Or a condition like mold, heavy metals could have impact on the response on treatment. And so I would say, the patient should definitely stay longer than 4 to 6 weeks on treatment protocol. Eventually, if we have evidence in one of these accompanying test methods that they are on a good track to extend. But without noticing anything for 10 months, I guess this is not appropriate. And then we have to start revising all the procedure and going back to the former levels to find out about these accompanying health condition, or if we have to rethink our diagnosis.
Okay, another question that was submitted before the event. This person would like to know how we can say for certain if the problems that persist after treatment mean the infection is active, or in fact damage the infection has caused to our bodies.
You know, this is exactly what I've mentioned several times in this webinar. So meanwhile, we can get these objective information out of the diagnostic tool. That is what we call the T-cellular testing. So this is a method where we can differentiate what it really is. It is still, in fact, active infection. Is it more inflammation or inflammatory processes, or is it immunosuppression? And we can read out what it is, and basically we can exactly determine the reason of good response or treatment failures.
Okay, there's 2 or 3 questions that sort of overlap. So, but in general, people are asking, for instance, in your years of experience and opinion, do you feel that people can fully recover or reach remission from chronic Lyme disease without the use of antibiotics? And there's a couple of other questions tied into that. Can herbs work as well as antibiotics? Could you say how they can complement each other?
Yeah, no, I guess this question is quite easy to answer. I guess the alternative treatment, so specifically the herbal antimicrobial, can definitely, or being able to replace the conventional antibiotics. So it's more or less a matter of time. So while running the clinic in Augsburg, we had access to a very big database, finally 28,000 patients over the time. And we have built up different cohorts of patients running only conventional approaches, mixed approaches, only alternative approaches to get a better overview and idea how the different approaches are working. And so summarizing, I guess the outcome in general is quite close to each other out of all these cohorts, and we have learned again it's a matter of time. So to give you an example, so on average, a patient with conventional approaches have to be treated around about 6 months minimum to get a good outcome. You can get the same outcome in mixed protocols within 9 to 12 months. And if patient decide due to any reason to go on alternative treatment, you can achieve the same outcome, but probably you will need minimum 12 to 18 months or even longer. So, and I have seen, so some of my serious ill patient I have seen over the past 3 decades have got really completely recovered only with the use of alternative medicine. This is definitely possible, but patient have to be patient in getting that outcome, and this is sometimes the hardest part.
how would you advise somebody who is particularly sensitive to treatment? In this case, somebody's asked that question because she's got secondary porphyria, maybe caused by Lyme or chlamydia pneumoniae. And I personally experienced that it doesn't matter what treatment you have, the reaction is spectacular. How would you approach a patient like that?
As we have considered here in the 2 days webinar, so the complexity of Lyme and its co-infection is quite obvious, and very often after a certain time dealing with chronic infection, you can expect onset of autoimmune diseases at the same time, which are quite challenging and can definitely cause some hurdles in treatment. So first of all, we have to find out what is present in patient, and then based on all these information, really to get up a good setup of treatment. And the treatment should include antimicrobials, and if patient due to any reason are not able to tolerate let's say complex trials with 2 or 3 antibiotics at the same time, you can definitely set up in combining conventional and herbal antimicrobials, or going completely on the alternative route. You can set up a good treatment plan. And as I said, this is a very individual patient-centered approach. And so with all these former use treatment protocols, so specifically in the 19s and in the 20s, so we have definitely noticed that this is not anymore a proper treatment approach. Yeah.
Okay, there's a few in the chat box questions about biofilm busters. Mm-hmm. Could you give some suggestions on your preferred methods,
sure.
Med or supplements?
Yeah, certainly. So there are many options. So one of my favorites is still a conventional approach based on the NAC, the NAC, N-acetylcysteine, which is definitely still one of the strongest and most effective biofilm busters. But there are also some herbal substances which can do pretty the same. There are some enzymes which you can use at the same time. So the matter of tolerance of the patient and the matter how serious the problem with the biofilms are. So sometimes it's helpful to introduce only one biofilm buster, but if patients are not responding in a proper way, you sometimes need also combination of certain biofilm busters at the same time.
Okay, somebody's asking, quite a few people seem to develop Raynaud's syndrome with Lyme. Could you give those people any advice about?
Yeah, so Raynaud phenomenon is in some kind acute vasculitis of the very small arteries in your fingers. This is a health condition which is very often combined with either a Lyme disease or Bartonella infection. So these both bacterial infection can cause acute vasculitis with the typical Raynaud phenomenon or Raynaud symptoms. And that could be sometimes a very tricky part of treatment, but it's manageable.
Okay. Another thing that obviously many people suffer from long term, could you recommend anything either herbally or lifestyle wise for people who suffer continuing joint pain, hips, knees, wrists, fingers and toes, etc.?
So, if someone is dealing with chronic pain or chronic inflammation of joints, it could be also a very complex problem. On one hand, we have learned that many specific infectious diseases can cause those problems. On the other hand, also autoimmune diseases, inflammatory process at the same time. So I would go for a mixed approach. So if there's evidence of infectious diseases, to go on antimicrobial treatment. for the causative treatment, or also for these so-called reactive arthritis issues. So some of the opportunistic germs like chlamydia pneumoniae, chlamydia trachomatis, and also mycoplasma can cause joint ailments. So we need definitely in some kind a causative treatment, but to reduce the symptoms and to get, let's say, the pain on a lower level, or the inflammation on a lower level, I would always suggest to put anti-inflammatory substances at the same time in a good treatment protocol. That could be something like omega-3 fatty acid, that could be the resveratrol, the bromelain, so enzymes which are very supportive to scale down local or general inflammation, and also a healthy lifestyle. This is what we call the anti-inflammatory diet. So to make it short or easy, so everything which we include in the Mediterranean lifestyle, so eating less meat, more vegetables, more fruit at the same time, is definitely more supportive for these patients in general with joint ailments. And there's some certain food, so processed food in general, and if it's come to the meat, you have to be careful with pork meat, with lamb. So then patients are more recommended to go on the white meat, like turkey or chicken, or from time to time a steak, but you have to avoid other forms as well. So so in summary, so the lifestyle, as well as some anti-inflammatory and antimicrobial supplements, could be very beneficial and supportive.
Okay, thank you. I'm just going to end with this question. I know that there's lots of questions in the chat box, and like I said, we will save them. We will save the chat box and see if you can answer some in your own time. But just to tie this seminar up, what would you say to people who think there is no hope of regaining their health?
So I have seen many patients, probably the worst of the worst. My former clinic, the BCA clinic, was well known to take care for this group of patients. I guess there is still hope, and sometimes it's a matter of time and really a matter of thinking out of the box to go again back in your staging to find out if patients haven't responded very well. So I've learned we have to be really focused probably on other health condition at the same time at these chronic infection. And in most of my patients, finally, we have found a good outcome. But sometimes it's not very easy and quite challenging. And I have seen a lot of frustration in my patient as well. And it took me sometimes a long time and effort to find a solution. But I would still say, in constantly improving our diagnostic tools and getting a better understanding, that learning about these bacteria, parasites, and viruses, and getting access to more and extended types of treatment, the chances had been never better than today to achieve a relatively or good outcome out of the treatment.
Thank you very much, Dr. Nicolaus. That's a really good positive end to this seminar. I just want to give the whole team at Lyme Disease UK, give you their thanks, and thanks for everybody who's joined today. If you found this series of seminars helpful, there will be another one upcoming, which will be advertised soon. I think it's towards the end of April, where Dr. Daniel Cameron will talk about Lyme disease in children and adolescents. Thank you so much, everybody. And thank you again, Dr. Nicolaus.
Yeah, thank you for inviting me. And I was really very excited to get the opportunity today to present.
Thank you very much.